Kia ora, everybody. Thanks for joining. We're just going to wait a couple of minutes for other people to join up, and then we'll get going. In the meantime, it'd be great if you could just pop something in the chat to do with patient safety. So the question I'd like you to sort of answer really is on a scale of 0 to 10, with 0 being the worst, most unsafe, and 10 being ultra safe, how would you rate Southern District as in terms of patient safety? So give a number from 0 to 10 in the chat. How would you rate Southern District for patient safety? Sam says 6. 6, 7 from Emma, 7 from Josh, 7. That's good. 7 from Claire. And for those of you who've just joined, we're just waiting a couple of minutes for people to join. But while we're waiting, we'd like you to put in the chat a number between 0 and 10, answering the question, how would you rate patient safety in Southern? So 0 being the worst and 10 being the best. Where would you rate Southern for patient safety? So far, we've got some people saying it's about 6, 7 seems to be 7 seems to be the median. Yeah, I probably feel the same round about that sort of thing. Certainly, I think we would struggle to find any promoters. You know, people are scoring 9 and 10, saying that this is a really safe organization, and I feel very good in here. I think probably that the patient view might be a bit higher, to be honest, because there are a lot of patients who come through here and don't experience harm. We probably have a different lens because we see it. We see lots of near misses, and we see the effects of the harm on the patients who do suffer it, and that really sticks in the mind. So yeah, certainly there's a lot to improve on, and I think nobody would disagree with that. So this is going to be about error and harm, and it's really a topic that has gained clout in the last 20, 30 years. Probably one of the biggest sort of step changes in terms of attitudes towards patient safety was earlier on in the 2000s, when there was a case in Britain where a young lady became brain dead as a result of a failed intubation. And when they looked at it, there were lots of sort of errors of teamwork along the way, which led to her having too much downtime. And there were plenty of skills in the room to be able to sort the problem out, but due to a lot of teamwork skills, it didn't occur. And the husband was an airline pilot and had grown up in an industry which itself went through a revolution in customer safety, and is now one of the examples of safety. And he started looking at the case through the lens that he used, and brought a lot of patient and airline safety sort of tips and techniques into healthcare as a result of his patient story. It was very moving. So yeah, in the last 20 years, it's really gained momentum. And healthcare is a very harmful place to be. And so there is plenty of things to look at and try and improve. I'm just going to share my screen now. So hope you guys can see that. There we go. So we're going to talk about the Swiss cheese model, which you probably have heard of. We're going to define active failures and latent error. We'll just discuss their roles. We're going to talk about unsafe acts using James Reason's classification system. We're going to explain why patient safety experts recommend focusing less on reducing errors and more on reducing harm. So what is harm? And then sorry, this is the lecture outline even. So what is harm? This is one definition of harm, which came from the IHI: unintended physical injury resulting from or contributed to by medical care that requires additional monitoring, treatment, or hospitalization, or that results in death. So what does this definition leave out? I'd like you to either put something in the chat, or if you want to, unmute yourself and tell me, what do you think this leaves out? Sam says psychological harm. Absolutely, yes. Well done. Yep, good. What else? Quality of life? Yeah, absolutely. Yep, definitely. Along the same lines as Sam, you know, thinking about holistic endpoints, not just sort of physical injury. Good. Yeah, what else? What else? Harm from non-treatment. Well done, Sam. Yeah, that's a good one. So the harm of not doing something can also be it's much more difficult to measure, because how do you measure something you've not done? But that is a source of harm. Good. Okay, so yeah, it's talking about the harm is unintended, but what about the side effects considered a necessary evil? So what do I mean by necessary evil? A lot of procedures that we do, there is a known complication rate. And no matter what we do, we can't seem to get rid of that complication rate. So a lot of people say, well, it's just a necessary evil. It's, for some people, it's inevitable. It's unavoidable. But they're still being harmed. So in this definition, they wouldn't be included. But I think in a better definition, they would be included. Medical care causes harm. So yeah, but this is about what are the errors of omission, just like Sam said: misdiagnoses, not doing some treatment that turns out to be the wrong choice, etc. And then another thing that Emma and Sam were pointing to, that harm is not just physical, it's also psychological. It can be financial harm as well. All of those contribute to quality of life. So yeah, quality of life is probably the ultimate way to measure harm. Harm leads to additional care. So, but what if the harm doesn't result in additional care? So what if the harm was something that the patient managed to cope with on their own? You know, in the previous definition, it wouldn't count, but I think that still counts, because from the patient's point of view, they suffered. So if you want to take a better definition, you could call it unpreventable events. And they're only innovation away from being preventable. So for example, central line associated blood treatment infections used to be considered an unavoidable complication. But more recently, with bundles of care, we've managed to get those infections right down. And it takes a systems approach to do that. So broadening the definition helps providers think of more places that we can reduce suffering and harm. So how does harm occur? Well, sometimes it will occur where there has been an error. So that's in the middle of this Venn diagram. But you can also get errors that happen without harm, so-called near misses. And you can get harm happening without any particular errors that one can pinpoint. And so in those situations, you could say, well, we think that the care has all been appropriate. You might do an investigation and come away with the fact that actually we did everything we could. Patient still had a harm. So there are two types of errors. Latent conditions are things where it's just the environment or the processes and systems just have an inherent risk inside it. So that's equipment that's been poorly designed, or even well designed. It's just that you can't get around some of the risks of it. I don't know, for example, IV pumps. They're very good and intelligent and stuff, but they're still a machine and things can go wrong with them. Active failures are much more immediate in terms of their effects, like somebody pushing the wrong button or ignoring a warning. And you can see a much clearer link between cause and effect from active failures. So active failures, because they're much more obvious and the cause and effect thing, people tend to focus on them a lot more. But you've got to also, if you are doing a root cause analysis, really look into the latent conditions, because those are the things that actually surface the active failures. So it's only in a poor environment do the active failures tend to occur. And we've all seen James Reason's Swiss cheese model. It's about lots of layers where there are some holes in it. The holes can be due to active failures, and other holes can be due to latent conditions. And in most cases, fortunately, the holes don't line up. So a patient will not receive harm from a hazard because along the way it will get stopped by one of the slices of cheese. But sometimes patients, unfortunately, experience harm because their hazard falls all the way through and past all our layers of defense, so to speak. Why does that happen quite a lot in healthcare? I think it's because we have lots of holes in our cheese. So classifying active errors. So we were talking about latent and active errors. This is just about active errors. This is quite a good flow diagram, but it's always difficult to commit this one to memory, I find. But it's worth working through to really sort of get an understanding of the different types of errors. So up at the top, we call everything sort of unsafe acts, things that could or do result in some sort of harm. And at the top, you can divide this into violations and errors. So violations are deliberate deviation from what we know is correct. So there are some rules in healthcare that we have to follow 100%, and there's no wiggle room for them. For example, hand washing. And if you don't wash your hands, you are violating a rule. So that's violations. There's quite a clear sort of understanding, and you can divide the violations up into those that are malicious or sabotage, direct sabotage, all the way down to sort of ignorance or callousness, and that takes you down the pathway of, oh, okay, is there somebody to actually blame for this, or is it just a non-blame sort of situation? Anyway, that's violations. On the other side, there are errors. So this is where we fail to carry out the planned action as intended, or we apply the wrong thing, wanting a certain result and not getting the result we want. And so you can say, well, does this action go as intended, or but it was wrong? So that would be a mistake. So a mistake is choosing the wrong treatment, or choosing the wrong piece of equipment for the job, or choosing the wrong treatment algorithm. That leads to mistakes. On the other side, the action does not go as intended. So we choose the right action, but the execution is faulty. And that's either because you've done a slip, so there's been an error in performing the task or the process, or a lapse is where there's been an unobservable or mental or error of execution. Okay, and we'll talk about some examples in the next few slides to kind of divide those two types up a bit more. So lastly, mistakes can be rule-based or knowledge-based. So in the rule-based mistake, the error comes from applying knowledge correct. There's an error implying knowledge correctly. So you have the knowledge, but you put it together and you come up with the wrong answer. X, 1 + 2 = 4, for example. You know how to add them up, you just didn't do it right. The knowledge-based mistake comes from a lack of knowledge. So, not knowing all the bits of the equation in order to come up with the right answer. So here's a bit of an exercise. If you could put in the chat your answers from 1, 2, 3, 4, 5. They're not numbered, but you can see the order there. What type of errors do you think these are? Okay, so I'll just go back a slide. You've got violations, and then you've got slips, lapses, and mistakes. Okay, violations, slips, lapses, mistakes. So the first one, you forget to tell your patient to schedule a follow-up appointment. So you forget. That's probably the key clue there, is forgetting. So we're getting some people say it's lapse. Josh says it's lapse. Emma says it's lapse. Good. Everyone else can keep putting your answers in there. Second one, you try to give your patient a pamphlet on healthy eating, but you grab the wrong one on sleep hygiene. So your intention was to grab the right one, but you grabbed the wrong one instead. So that would be a slip from Sam, Josh, everybody's saying slip, okay. Third one, you don't wash your hands because you're distracted. What would that be? That'd be a mistake. Mistake, slip, okay, some disagreement on this one. Emma said that was a violation. Okay, we got a range of answers there. We'll see what the answer is in a minute. Fourth one, you don't wash your hands because you don't feel like you have time. So number 4, what's that? A violation? Two people saying this violation. Violation. Okay, a bit more agreement on that one. Last one, you misdiagnose your patient's pain. Misdiagnose your patient's pain. Yep, it's an error, but what type of error? RA20. Mistake, most people saying mistake. Okay, let's have a look. So lapse, slip, lapse. So that was the one where we disagreed a bit. You don't wash your hands because you're distracted. So if you weren't distracted, you would have washed your hands, but something took you away. So it's not a deliberate act, so it's not a violation. And it's not a slip because you didn't wash your hands in the wrong way. You just forgot to wash them. So it's a lapse. Yeah, and then we had basically agreement on all the others. Well done. Okay. So this slide is about, moving away from trying to reduce errors to trying to reduce harm. And it's thinking about the conditions under which people are working. So thinking about the environment that's contributing to the errors and the harm. It's thinking about designing a workflow and defenses to avert errors. So trying to prevent those errors and harm in the first place. Minimizing the conditions that lend themselves to violations and putting mechanisms in place to mitigate the effects of unsafe acts that may inevitably occur. So thinking about like hand washing, which is something we all have to do. What do you think some of the systems approach thinking of these things might be to reduce the harm caused by not washing our hands, and the harm caused is increased healthcare infections. So, does anybody want to unmute and give us an idea or an example even?
I'll do it.
Oh, thanks very much, Emma.
The availability of sinks and more sinks, more likely you're going to wash your hands.
Yep, good,
And
excellent.
example for from where I work here in the cath lab, we had one sink in the corner, which was the scrub sink, which was the opposite end of the room to where the physiologists and radiographers were. So they often wouldn't go to the back room to wash their hands because they'd then have to leave the room. They've since put a new sink in their area, and the hand washing hygiene has improved markedly.
Fantastic. That's a great example of just looking and looking at what the conditions under individual people are working and change the environment to improve the performance there. So that's a really good example. Thanks very much. Good. Okay, we'll move on. So I touched on this a bit before, but we'll go into a bit more detail. Determining blame versus accountability. So we like to think that we work in a blame-free culture. That was something that's banded around about 15, 20 years ago. We need a blame-free culture. And the reason that we wanted a blame-free culture is because then people would feel completely open to be able to speak up about any errors and stuff they saw around them. And that would be the start of addressing errors and a systems approach to that. Unfortunately, we don't live in a fairyland like that, and there needs to be accountability in healthcare. We just can't get rid of it. But we don't necessarily need to point the finger all the time. So it's a real fine line between blame and accountability. And unfortunately, on the receiving end of criticism, it can feel like blame all the time. And also, to be honest, professionals who end up in front of their regulatory body for particular adverse events are getting the finger pointed at them, and they are being blamed. So it will never be a blame-free culture, but if we can at least talk about more about accountability versus blame, it can help or can soften the blow. So practical questions determining between the two here would be, did the individuals intend to cause the harm? And trying to determine intention can be difficult. It can be difficult to determine whether somebody intended to kill somebody or whether it was just a bad consequence of their stupid actions, and that's why we have courts for that. But of course, we don't put people through courts here, so for smaller things. But yeah, trying to determine the intention can be difficult. Did they come to work drunk or impaired? So obviously that's quite an easy thing to define, sometimes difficult to detect though. Did they do something that they knew was unsafe? So were they just being callous? They didn't take any care over how this would affect the other people, but at the same time, they weren't intending to necessarily cause harm. It wasn't maliciousness, but it was callousness. Could 2 or 3 peers made the same mistake in similar circumstances? This is probably a good test, actually, because it is the test of reasonableness. And often, if something's happened and you want to, test the water a bit more, go and speak to a few of their peers in confidence and say, what would you have done in this situation, and get some other ideas there. And also, do these individuals have a history of involvement in similar events? So one other thing that I learned from a great conference I went to is that it's often possible to spot the dangerous doctors or healthcare professionals because they have, on average, way more complaints about them than other people who are much safer. So complaints against a particular individual, from usually from other staff, but also from patients, it can be a red flag sign. So this is a good decision tree. It kind of helps you separate out the spectrum between people who are being malicious, trying to sabotage things, and on the other end, it's an error, but there's nobody to blame. And then there's everything in between. So you can see there's all shades of blue or all shades of gray, basically. So if we were talking about a scenario which probably happens quite common, and it's hand washing again, because it's an easy one. So say a person saw a patient and then walked away and chose not to wash the hands because, I don't know, they were rushing to get somewhere, and they saw the sink and then made an active choice. Okay, I don't have time. I'm not going to wash my hands, and just rush out the door. So what would that be? So were the actions as intended? Yes. It intended not to wash the hands. Were the consequences as intended? Well, I don't think they were intending to harm anybody by that. So that would be no. Unauthorized substance? No. They weren't drunk? No. Knowingly violate safe operating procedures? Yes. Everybody knows you've got to wash your hands. So if you're not doing it, you're violating it. And it wasn't just that they forgot to, they made an active choice to walk past the sink and not do it. Were the procedures available, workable, intelligible, and correct? Yes, they make it available. So yes. So possible reckless violation. So you can see that comes down quite hard on somebody who chooses not to wash their hands. But of course, the culture in the organization would say it would probably rate that violation slightly less than recklessness. I would call it, you could call it somebody who is being, I don't know, very selfish, maybe selfish, reckless. I don't know. And when you call somebody reckless, you're saying that they are unprofessional. You're saying that they are a danger to other people. You're saying that they need a close eye kept on, and certainly correcting. I would say that in order to get to that level, and now I'm just speaking in sort of the context of the culture, that a one-off violation wouldn't be called reckless, but if somebody is repeatedly doing it, then that would be reckless. So this is where you need the information of the system to be able to pick out individuals who are reckless, and that means getting complaints in, getting 360-degree appraisals, collecting that data before you can call somebody reckless, and then actually bring in the big guns to correct that problem. So it's very, very difficult to actually put somebody down on one line of needing individual attention to just, if nobody reports it, then it always seems as a one-off thing. So that's a really interesting way to think about this. So in summary, patient safety field has broadened its focus from reducing error to also encompassing efforts to prevent harm. Active errors are signs that latent errors are present. So as again saying, the environment kind of raises the risk in terms of active errors happening. And eventually a hazard can slip through all the holes and cause harm. And system failures that lead to serious patient harm are rarely the result of just one error involving one person. Okay, there's typically a series of breakdowns in processes. And we see that all the time in adverse events. It's why we do things like root cause analysis and another tool called 5 whys. So you might use the 5 whys, asking, why did this happen? Okay, and why did they do that? And why did they do that? And you do that 5 times until you potentially get down to the root of the problem. Okay, so now we're going to watch a video. And this video is quite interesting from a non-healthcare point of view. So we get to see another industry in action about safety. I need to share my sound, so just a minute. I think that's going to work. Oh, yeah. Just turned my video off by accident. Okay. So put in the chat if you can't hear this, but we're going to start the video. Oh, sorry, can't hear. Okay, sorry. Yeah, no. Here we go. I found the right button. Okay. Start again. Tell me if you can hear that now.
We go outside of healthcare to see our system in a new way and get fresh ideas for improvement. Today we're going to learn about a safety system to handle a totally different hazard, one we rarely face in healthcare. We're going to look at dangerous snakes.
Hi, I'm Kathy Duncan, and today we're going outside of healthcare to the Central Florida Zoo.
The Central Florida Zoo has a lot to teach us about safety. Specifically, we're going to learn 3 valuable lessons about reliability. In order to create reliable systems, we need to prevent failure, identify failures and mitigate their effects, and learn from failure to better design our systems. How does the zoo apply those concepts when handling venomous snakes?
My name is Michelle Hoffman. I'm a reptile keeper at the Central Florida Zoo. I've been here for 4 years, and I work with one of the largest collections of venomous reptiles in the Southeast within AZA zoos.
Michelle took us behind the scenes to show us how they stay safe when handling snakes, to clean their enclosures and to move them.
The red and the green cage cards actually will tell us at a quick glance if the snake in the enclosure is venomous or non-venomous. So the red obviously is the venomous, the green is the non-venomous, red stop, green go.
And what's this number 1 up there?
The numbers above the enclosures actually tell the keepers how many animals are in the enclosure. So for example, there's only 1 Aruba Island rattlesnake in here, and there are 3 pythons in that enclosure. So we know if we open the door and we only see 2 animals, there might be 1 hiding somewhere, to keep your eyes open and actually find all of those animals before you reach in or before you do any work in the enclosure.
All this helps prevent snake bites. But what if a failure does occur? When keepers handle snakes, they work in pairs so that if something goes wrong, there's a trained person there to help them.
We're expected to work really closely with our coworkers and our managers. We have a very open relationship when it comes to trust and being able to speak up.
They also use a belt clip with key information about the snake, such as the antivenom.
So that way if something goes wrong, somebody can come in from the outside, know exactly how to handle the situation and which antivenom to bring with you to the hospital.
This helps to reduce harm if a failure does occur. The next principle of reliability is that you may redesign your systems based on what you've learned from failures.
It's been over 20 years since we've had a venomous snake bite here at the Central Florida Zoo, and one of the reasons for that great track record is because we were always adapting and adjusting and learning how to improve our systems to prevent any failures in the future.
For example, they used to use a lanyard instead of the belt clip with all the snake information.
We actually switched it to the belt clip in order for it to be completely out of our way and not in any sort of position where it could get attached on anything or a snake's tail could get hooked around it or anything like that.
They also modified their trash barrel to have a plexiglass window on the top so that they could see where the snake is.
One of the main ways that we do learn is from other people, other facilities, other reptile professionals. So we are expected to have close relationships with those colleagues. If we have a system that maybe went a little bit wrong or that maybe wasn't working out the best, we can go to them and ask for advice without feeling like we're inferior or something like that.
Every time I visit the zoo, I see opportunities to standardize, mitigate failure, and even redesign the work. But they've taken opportunities to really look at how they can keep not only their keepers safe, but they can keep their animals safe. So as you go about your daily work and daily life, look at other opportunities to really see how you might can bring things back to healthcare.
Okay. So, I always enjoy watching that video. I've seen it 100 times now, but I still like it. And it's got some really great examples of systems thinking. So, let's have a discussion. People can unmute and give me their opinions. So the first probe really is the video lists 3 principles of reliable design. How have you seen the same principles applied elsewhere, so in your areas or in previous roles?
Sorry, James, could you just outline the 3 principles again?
Yeah, so so if you saw, one was where they had clear signage on outside of the pens to show what was inside, whether it's dangerous or not dangerous, and how many animals there were in there. So that's designing sort of fail-safe ways of understanding things in there, you know, good signage and all that stuff. So that's that. And the other one was then what do you do in an emergency? So if you do get a snake bite, how do you make it easy for the right treatment to be given? So that was with the belt clip with the different anti-venom listed on there. You had numbers, and then when you open the fridge, it's easily identifiable what you need, plus that red switch to flip if there was an emergency. The other one was working together with the other co-worker in pairs, so that if something did happen to one, then there was another person. So that's what you might call redundancy, so that where the system has redundancy. And then the last one was a culture of continuously improving. So they were always looking at ways to improve their systems. And how do you learn that? Well, you learn that from near misses, and you learn that from other organizations. So yeah, so those were the principles they were talking about.
Cool. I mean, one thing, gosh, and this is a previous role, I was quite impressed with the way the New Zealand Army has some of their similarly has some standardized processes. So ages ago I was in the reserves, and the reserves is a, oh sorry, I'm just going to move my screen because I'm looking off to the side. The reserves is a particular challenge because it's part-time, well, very part-time soldiers. They typically do a weekend a month.
Yeah.
So they're don't have the same training, and they have to do some quite dangerous activities. So one activity you have to do is every year you have to throw 2 live grenades. So you've got folks who are doing this on a very part, and it's not even, to be honest, it's not even a weekend a month, because you get busy and you skip months. So actually sometimes there is a certain number of days, I forget what there is, but there's actually not even be 20. So you have people who are spending probably less than 20 days a year, or spending around 20 days a year actually doing an activity. So you actually got a workforce that doesn't necessarily have the skills, and you got some quite inherently dangerous activities. So what they did tend to do is very similar to that. They had very standardized processes, like for the grenade throwing, it was and similar to that with the peers, it was there was multiple people involved. There was a clear person in charge, so that was an officer. He was in a watchtower. And then there was a senior NCO with the actual person who had to do the grenade throwing. And there was all this protective equipment. They had kind of the shield stuff, but there was also a very set process. So the NCO would say, "Yep, we're ready to throw." The officers say, "Yep, you can go ahead and throw." The NCO would say, "Throwing," and throw, and then the officer would count, and then at a certain count, he said, everyone heads down, and then everyone would go down. And they also had set processes that say if someone got nervous and dropped the grenade, then there was a set emergency process for that. So yeah, I thought that was quite impressive. So they're managing actually having very inexperienced staff, really, through having a very clear process with lots of redundancies and lots of backups, everyone knowing what they were doing.
Yeah.
So yeah, sorry, I just want to say that.
Yeah, that's great. So yeah, standardized processes help you not make mistakes. Did they use any simulation before they threw the live grenades?
Yes, no, absolutely. So you're practicing with completely inert ones, and then I think from memory you might have done 2 kind of simulated ones that explode a little bit, but not much before you actually did the real deals. Yes, There's lots of drills, repetitive drills as well.
Yeah. So that just really ingrains those systems and those standardized processes, so that people don't forget. There's no slips and lapses, and hopefully no violations. Yeah, great. Thank you very much, Sam. So next question. Teamwork and a culture of transparency and trust are important to protecting safety. How do you think teamwork promotes each of the principles of reliable design? So to make this more relevant, are there any examples in your area where your teamwork, the way you work together, promotes safety in what you do? And some of you might be in administrative roles, but you can guarantee that because patients are all our customers, what you do, mistakes in what you do could lead to patient harm. So work in your team to reduce errors will still be of real importance. So has anybody got any experience or anything to share from their team environment?
I'll share something. We've recently started implanting defibrillators, and the programming of those is obviously quite important. And it's quite complex. So, and you're doing it kind of in a darkened lab, you're doing it at the time of implant. So we always get someone, if it may not necessarily be a colleague, it may be a company rep who we kind of do it via video call and get them to double check all the settings. So we just sort of make sure that, everything is programmed correctly and everyone's happy, because it's easily, you're just pressing a button. You could easily press the wrong button or put the wrong number in. So we kind of make sure that, we've never had any programming errors from an implant.
Great. Yeah, thank you. That's really good to hear. And a good example of redundancy in your system, checking, making sure that somebody else has a look and making sure that it's right. In my area, a good example of teamwork and culture would be in our monthly mortality and morbidity meetings, which have been going on for about 30 years in surgery. So this is where we spend an hour sitting down discussing patients who have suffered complications or deaths, and we present the case to each other, and we are open and honest about areas which we think may have contributed to the complication or the death, and also, is quite self-reflective, so we can usually is the environment feels safe enough to say, I think I didn't make the right choice in this situation, and looking back, I probably underestimated the effect of this, and I didn't quite pick up on this, and that led to this outcome. So that culture of being able to stand up in front of your colleagues and say, I think I made a mistake here, is met with very little sort of blame, and criticism has said, well, I might have done this differently, I might have done this and this and this, but of course all the time we're assuming that it's very difficult to stand there and say you did the wrong thing, because there are usually quite a lot of nuances to any clinical situation, and unless you were there at the time, it's very difficult to say that you would categorically not choose the same way that another person chose to decide. So that culture really does allow us to identify areas for improvement, and also is a safe way for the individual to really be self-reflective and look at if they do need to change their practice in any way, that they can do it without any sort of major sort of consequence to their reputation or their career. Great. So what would happen if the zoo waited to redesign its systems until an actual failure, not just the possibility of a failure, so not just near misses had occurred? You know, what if they just carried on doing the same thing, and then if an actual failure occurred, that's the only time that they would change things? Okay. Well, that's kind of what we do in healthcare, to be honest. The only thing that really spurs actual change is when an adverse event report, so that's a report from actual harm usually, and it's usually only the serious harm, you know, where the patient has been harmed seriously, permanently usually, or has died. And only those cases kind of trigger some investigation that leads to recommendations which are still poorly applied, to be honest. And it really is probably only when the HDC gets involved, that's the Health and Disability Commissioner, kind of comes in and does an external review and points the finger at certain things and people and systems, before we're actually then compelled to make changes. And again, that system is probably flawed because the HDC don't have the resources to keep chasing all the districts up on how well they're doing with their changes. So changes that are made are usually probably not sustained effectively anyway. So yeah, I think there's a long way to go between the zoo and some of our healthcare systems. So in your experience, are healthcare systems more often proactive or reactive when it comes to addressing safety issues? So have you got any, you know, bad examples like I've just done, or good examples in your area where you are actively being proactive about preventing failure rather than just being reactive? Anybody got a drum to beat or complain like I have?
Oh, sorry, James, I'll jump in. I mean, there is a lot of reactive stuff. I work with John McCarthy, who does the investigations, and obviously there's a lot out of that. I guess, I mean, one thing that is good on the proactive side, I also work with Glenn Orton on this certification against standards, and I guess you could say that's a little bit proactive in the sense that we you know, have these certification audits and they identify issues or potential issues, and then we go out and address those. So I guess that's, you know, sometimes a good audit process yeah, can be seen. I mean, you could probably argue about that, but can be seen as proactive. But yeah, so certainly there's a lot of work generated through adverse events and you know, HDC complaints and so forth.
Yep. Yeah, I mean, I struggle to think of truly proactive programs going on. I think your example there of certification and sort of audit is a good one, actually. The other ones that I can think of that could be proactive but not really used in a proactive way enough probably is the Health Roundtable data that comes through the system, but we kind of use that just to spot problems rather than use it as a tool to improve and find sort of things to improve. I think we're just looking for, again, reacting to things. So if we see we're kind of middle of the road for something, we'll kind of just leave it. But if there's a spike on, I don't know, mortality or something, then that's when we would kick in. That's still reactive, really. What else is possibly proactive would be where the Health Care and Quality Commission launch a new sort of project to try and reduce the rate of such and such. But often those projects are off on the back of a particular sort of failure in somewhere that's then identified as a risk for everyone, and then it's spread around. So it's still potentially reactive, but when it lands in most organizations, those projects are really quite proactive, so they're good as well. Good. So that really brings us to the end of what I wanted to introduce in this vast topic. Let's just unshare the screen. And I was just wondering, just for the last couple of minutes, if people have got any questions about patient safety, or if you've got any questions about this course, which you should be probably about halfway through. Some people are a lot further through than that. Some people have only done 1 or 2 modules, and that's also fine. So are there any questions with regards to those things?
Oh, I just want to say, James, that I probably enjoyed the online module for this the most. I quite like the content, and I like the focus on the system and the idea of trying to, you know, create basically this is a terrible way of putting it, but foolproof systems, or kind of not, you know, trying to create systems where, because as it kept on saying, you know, errors are just going to happen. People always going to have lapses. They're always going to have slips in particular. So how can you design a system that can tolerate that and kind of offset that, or alert that? And I think that is always a good thing to focus on whenever there's something happens. You could take a, you know, zoom out and say, how can we design the system in a way that prevents this, you know, rather than jumping to, well, that person just shouldn't have done that.
Yeah.
Particularly on.
Sorry, Sam.
Yeah, no, it's fine.
Jump.
I've been involved quite heavily with the Newton Eden Hospital design, and we've got to some points in some of the flows, and we've looked at the flow, and we just thought this is going to be a hot mess if we have an emergency, because everyone's going to be running against each other, and you know, so we've had to scrap it and go back to the beginning. And of course, the whole design is flawed with, you know, no money and make it smaller. And everything has to be versatile, so it's been quite a challenge. But yeah, I think just being involved in emergencies kind of frequently, you know, if rooms aren't set up to flow well, particularly in you know, interventional procedures, it can really cause harm, you know, maybe not harm, but it doesn't help you know, the flow of any emergencies.
Yeah, absolutely. So I mean, those are 2 great things. I've got some things to say on top of those. So just taking your one, Emma, when they were redesigning the Christchurch Hospital, they actually built, they took a warehouse over in Christchurch, which is still running, where they can mock up environments. So like they mocked up the ED, the new ED out there, and got a lot of staff to come in and actually simulate the running of an ED. The way that the layout they initially designed it, and they used that simulation to identify lots of flow issues and patient safety issues, and that allowed them to redesign the area. So that would be a great thing, and I think people have asked for that for this hospital, but I don't think we've actually had that yet in terms of that sort of attention to design and trying to simulate the areas and refine them before we actually put them into sort of jib and actual physical areas. And in reply to Sam on the topic, so the patient safety is a really rich area for quality improvement, because you know, if you talk to an accountant, they don't get it, or a lot of accountants wouldn't get it, as to sort of like, well, that's all very well and good, but it sounds like it just ends up costing more and more money. But they've done a lot of studies on this, and actually, you know, a safe system costs a lot less to run. So in the end, although you can't really draw a direct line between a patient safety initiative and dollars saved, in the end, you'll find that the safer organizations, and you see this in US healthcare organizations, the safer ones are actually more efficient in terms of their spending. So that's one way to persuade people about, patient safety stuff is really, really important, not just because we don't want patients to get harmed and we want staff to deliver excellent healthcare, but it's actually cheaper to run. So you got, on the one hand, some quality improvement initiatives, which are quite a lot of them that come through the organization that are mainly geared at saving money, and very little patient safety ones coming through the organization because they're not really directly affecting the bottom line. But actually, if we had a completely different focus coming from the top, I would like to see it around the other way, to be honest.
I work in Southland and I do a lot of quality work, mainly around SAC 1s and 2s for the leadership team. And the thing that concerns me the most is the amount of things that aren't entered into safety first. So I feel like there's a huge amount of patient safety near misses that are being missed due to them not being entered. And quite often I'll hear about things secondhand, I'll overhear things, and I'll go to look to sort of see what's going on. And quite often there's no record of it anywhere.
Yeah.
So I feel like there's a lot of patient-related safety stuff.
And why do you think people don't enter stuff into safety first?
It's too hard. The system's too hard to use. I get that comment a lot. It's time consuming. They've passed it on to somebody further up the food chain and they haven't entered it either.
I think I agree with that. And I think another reason why people don't enter stuff in, or another two reasons, is one, they don't get any feedback from anything they enter in. So it's like you're chucking something into a rubbish bin, really. I mean, it's like, what is the point? I don't get any feedback. I don't know if my comment's going to make a difference at all. And then the second thing is, well, I know it's probably not going to make a difference because I see the amount of quality improvement work that goes on around me, and I can see how much fails all the time. And I can't really think of the last time something came through and the top brass paid money for it, So why are you bothering improving an organization that doesn't have any capacity to improve? And that's the perception of a lot of people. And I probably understand why people perceive it like that. So it's a big culture problem.
Yes, very challenging. Yes, I come from a background in aged care where we were very thorough with entering things. So it's been quite a very eye-opening experience moving to a more broader healthcare.
Yeah,
I can see why people are reluctant to do this, because they get the same thing over and over and over again.
Yeah. Well, that brings us to 1 o'clock, and I don't want to keep you late. So thank you very much for your participation. If you still got any questions about the course itself, very happy to hang on for the last few minutes and talk to you about it. But otherwise, have a great afternoon. Cheers.
Thanks, everyone. Thanks, James.
Thanks.